ma'am, for that great presentation. Next we have the Chairman Scientific Committee of All India Ophthalmological Society, the one and only Dr. Santosh Honavar. The General Secretary. Every time you think of Dr. Santosh Honavar, you think of science only. So, and Sir is the Honorary General Secretary of All India Ophthalmological Society, and he's doing a wonderful job with so many innovative programs. And I think Sir will be speaking on targeted therapy in ocular oncology.
Thank you, Srini. You went back to your old tagline. Well, I'll be speaking on something that is new that is happening in the field of oculoplasty and ocular oncology, that is targeted therapy. Now, what exactly is targeted therapy? This is generalized medicine. When you give a particular medicine for a particular disease and expect it to work in everybody, that is not possible. It's not going to happen that way. When you stratify patients based on disease subtypes, demographics, and clinical features and use biomarkers, then that is stratification. Go one step further, and that is personalization, and we are heading towards precision medicine where there are molecularly targeted therapies. There are many types of cancer treatments, and targeted therapy can be based on molecular targets or organ-targeted tumor-specific drug delivery, which is intraorbital and intraocular, intratumoral as well. What exactly is targeted therapy? It is molecularly targeted therapy by definition, which is a form of precision therapy, which targets specific genes and proteins in cancer cells that help them grow, divide, and spread. Does not generically target all the rapidly dividing cells, thereby side effects of these treatments are going to be very less. There are hundreds of potential targets and hundreds of potential deliverables. This is a totally unexplored field. We are just scratching on the tip of the surface at this point in time. What are the aims of such a targeted therapy? You already know that it could be curative, it could be neoadjuvant where you have planned certain surgical intervention, and before that you want to do this to shrink down the tumor so that your surgery is less invasive. Adjuvant, after having done surgery, you want to make sure that you mop up the entire disease by using these drugs. And palliative, make the patient live longer and the quality of the life not to be affected during that process. The first step is always to identify the mutation. Like in basal cell squamous cell carcinoma, melanoma, sebaceous gland carcinoma, Merkel cell carcinoma, all these of the eyelid and the orbit, we already have several of the molecular targets identified. We know that these are the targets, and for each of this particular target, there is a drug. For example, in conjunctival melanoma, the mutational spectrum has already been identified. The basics are to identify what a particular drug is. There are IBs and MABs of targeted therapy. Whenever a drug ends with IB, that is a small molecular drug. Whenever it is a monoclonal antibody, that ends with MAB. That is how the drugs are designated. Now there is a nomenclature of monoclonal antibody policy 2022, which further classified as MIB, NIB, and NAB. I won't go into the details. Now these are the small molecules that we are already using. Vismodegib and sonidegib for basal cell carcinoma. For squamous cell carcinoma, we use EGFR inhibitors or epidermal growth factor receptor inhibitors. Erlotinib is available in India. Anaplastic lymphoma, we have crizotinib. And for metastatic adenoid cystic carcinoma, we have pazopanib. Many of these drugs are becoming available in India for systemic indications, and we can use the same drug for orbit as such. This is vismodegib, which acts against the hedgehog pathway. This is a patient which was reported earlier with basal cell carcinoma multifocal, where there is a role for vismodegib. This controls the disease. As you can see, without surgery, most of these tumors have regressed and have remained stable, but it is a treatment that is long-term. The patient has to continue to take it. In certain situations where there is an orbital extension of basal cell carcinoma where the patient is inoperable, again you can use to temporize the situation. This is a patient where there is right eye wet ARMD, he can't see. Left eye, which was making him mobile, has been displaced up by this orbital tumor, but he is inoperable because of systemic conditions. So he was given erlotinib. You can see that the tumor has shrunken and his eye visual axis has been restored. So he is able to see as long as he lives and succumbs to other diseases. Now, it's said that people with ropes don't always have to hang. This is one such example of a sebaceous gland carcinoma, which is potentially exenterable. But now with targeted therapy, which is of course a combination of cisplatin and 5-fluorouracil, you can see that the tumor now has resolved to the extent that it is excisable locally. Only the medial 2/3 of the tumor is left. This was a variant of sebaceous gland carcinoma in the lacrimal sac. Somebody has done a DCR earlier. Now this patient has 20/20 N6 vision. Why exenterate him? With targeted therapy and then DCT and then stereotactic radiation, his tumor is gone and he is living on. Small molecules actually make a much big difference. We have many tumors that are being treated as such. Now this is an example of BRAF inhibitor, vemurafenib, which has been treated with orbital use for orbital Erdheim-Chester disease. This was my own patient of thyroid eye disease, young patient with IgG4 overlay. He responded initially to intravenous methylprednisolone and then rituximab, but finally when he relapsed, what controlled him was bortezomib, which is a newer drug which is available in India, not very expensive. For neurofibroma type 1, earlier we thought that it was a surgical disease. It does look like a surgical disease. Now we have medicines for neurofibroma, not just plexiform neurofibroma, even optic nerve glioma that is associated with neurofibroma. We have targeted therapeutic agents. We have several monoclonal antibodies, rituximab for orbital lymphoma, and immune checkpoint inhibitors such as pembrolizumab for melanoma, which is extending into the orbit. This is from the literature. Nivolumab, conjunctival melanoma from the literature. My own patient with nivolumab, he had regional lymph node metastasis. He had multifocal melanoma recurrent in the conjunctiva. We got approval from the insurance company for regional lymph node metastasis. He started using it. 3 months later, you can see that the tumor is completely resolved. I didn't have to do any surgery at all, making it a case for possible primary treatment, at least of inoperable diffuse patients using these targeted therapeutic agents. In uveal melanoma, we have the entire mutational spectrum worked out. We have now classified uveal melanoma into group A, B, C, and D disease, each with a different prognosis. And for patients who have a bad prognosis, we can definitely use many of the treatment modalities which are being currently tried. We also have organ-targeted tumor-specific drug delivery system. For lymphangioma, we can use picibanil with good results. For eosinophilic granuloma, we can inject intralesional triamcinolone with complete remodulation of the bone over a period of time. For apical or orbital cavernous venous malformation, we can use intralesional bevacizumab with reversal of visual field defects. For lymphoid hyperplasia, benign reactive lymphoid hyperplasia, we can use bevacizumab injection and rituximab as well. And this is my own patient with orbital lymphoma, conjunctival component excised, residual lesion treated with perilesional rituximab. Of course, we can use that for retinoblastoma as well. In conclusion, I would say that targeted therapy has just put its foot into the field of ocular oncology, and we have a long way to go, I understand, but these are going to be the next level of care in oculoplasty and oncology. Thank you so much.
Thank you, Santosh sir, for this wonderful talk on targeted therapy in ocular oncology. Sir, please be there on the stay back on stage. It's a great privilege to have the Honorary General Secretary of AAOS, Dr. Santosh Honavar, the Chairman Scientific Committee of AAOS, Dr. Namrata Sharma, Media past President, and my teacher, Dr. Lalit Verma on stage. Thank you all for being part of